Good afternoon to all. So I'll be discussing about endocrine emergencies now. And as sir rightly said, diagnosing them is the tricky part. Once we have diagnosed an endocrine emergency or any endocrinology case per se, the treatment is usually fairly forward. It is a simple thing. But diagnosis is a tricky part because one, they are relatively less common. Second, there is a lack of awareness in general about endocrine disorders because we don't usually discuss these in such forums. And third, a lot of ambiguity comes when we see the reports. Seemingly normal report cannot be normal. So we will see such things in my presentation. So my case 1 is a 54-year-old male who is a known case of diabetes, hypertension and Graves' disease. And he had a road traffic accident and he presented with polytrauma and blood loss, and he was admitted in the intensive care with this. His systolic BP was 90 mm of mercury at presentation. Heart rate was 130, expected for a lot of blood loss. His saturations were fine on room air. So he was stabilized, and PRBCs were given, IV fluids were given, antibiotic cover was also started. His pan-CT was done and there was no major abnormality in his CNS, thorax or abdomen. So next day he was fairly stable, and he was maintaining a blood pressure of 110/60 on vasopressors. Heart rate was around 120 to 140. So it was decided that since he had a big femur fracture, that he'll be taken up for the surgery. So he was taken up for the surgery, and next day after the surgery he started developing fever spikes up to 103, 104 degree Fahrenheit. His blood pressure now started dropping. Even with high dose of vasopressors, he was maintaining a blood pressure of just 100/60. His heart rate was 140, and he now developed a new onset of breathlessness. His WBCs were not that elevated, something that we can anticipate with so much stress. Cultures were sent. So for this new onset breathlessness, his echo was done, and it showed that there was an reduced systolic ejection fraction of 40. There was AF on the rhythm showed AF, and he had developed new Krebs. So after the last presentation, I think it will be fairly easy to diagnose what that patient must be having. He was a known case of Graves' disease, right? So when the thyroid profile was looked into, his T3, T4 were elevated, TSH was very suppressed. So for the Graves' disease, the patient had been using methimazole at 20 mg. And the last follow-up was 6 months back, and the son said that there was irregular use. They were not sure whether he was using or not. So then what to do? Now we know that we have a patient diagnosed with Graves' disease. The T3, T4 are elevated. What do we do? Do we increase the dose of methimazole or do we do something else? Any guesses would be welcome. Okay, so usually in such a scenario, what we should do is see if the patient is in STORM. So there is a criteria called Birch-Wartowski diagnostic criteria. It is a very simple criteria. It takes into account some 4-5 things, including temperature, central nervous system, whether the patient is agitated or severely comatose, or some GI or hepatic dysfunction, cardiovascular dysfunction. So it takes into account tachycardia, heart failure, and presence of atrial fibrillation, and history of a precipitating factor. So more than 45 if the point scores, that means that the patient is already entered STORM, and if it is between 25 to 45, it means that there could be an impending STORM. So our patient score was 70, so he was in STORM. So thyroid STORM is a rare but life-threatening condition. Usually it happens when the patient is having long-standing untreated hyperthyroidism, but sometimes, as in our case, the patients who have stopped using or are very irregular with their thyroid hormones can also present with a crisis. Usually there will be a precipitating factor. They can be having infections, surgery, trauma, or even during delivery. And once we have a diagnosis of STORM, we go very aggressively for treatment. We give a beta blocker for rate control, we give PTU, hydrocortisone, iodine, cholestyramine, and of course supportive care and treatment of the precipitating cause. So again, I'll be focusing mainly on diagnosis because a very high index of suspicion is needed to identify STORM, as sir previously said. So anyone with hyperthyroidism, if there is a history of hyperthyroidism and he comes to the ICU, we already know that he has come to the ICU, so the precipitating factor is already there. So do look for other signs and symptoms. So mainly cardiovascular, that is any AF or CCF, or altered mentation. So if there is hyperpyrexia, cardiovascular dysfunction or altered mentation, we should definitely evaluate for a storm. Again, the thyroid levels in a storm are not like they're very out of proportion to someone who presents with a regular thyrotoxicosis. They are similar. They will have almost similarly elevated T3, T4. So in all such patients, the only thing that we have to see is we have to see if they are meeting the criteria, because just increasing methimase won't solve our purpose in that case. We have to get very aggressive because mortality is very high. But if we identify and hence treat them aggressively, the results are very rewarding, and most of our patients do live. So second case is a 68-year-old lady who had Parkinson's and diabetes. So she basically had been having a lot of episodes of dizziness and falls, and this was typical when she was standing up. So she was diagnosed to have postural hypotension, and basically because of all these there was some slowness of activity, there was postural hypotension, so she was diagnosed to have Parkinson's since last 1 year, Parkinson's plus probably, because there was a lot of postural hypotension associated with it. So the patient had become so disabled that he was not even able to go to the washroom without support, because whenever he would get up, he would just fall down. So when his sodium was sent, it was very low. So he had severe hyponatremia. So that is why he was shifted to the ICU, and 3% NS was started. His urine sodium was less, it was 10. Urine osmolality was also on the lower side, 45. And it was evaluated whether he was taking any diuretic or any other drug that could cause hyponatremia, but nothing was there. But he had some history of decreased appetite since the last 2 weeks and had been having vomiting since the last 3 to 4 days. So after correcting the sodium with 3% of NS, it did improve, and later on for postural hypotension, fludrocortisone and medodrine were also started. So earlier sodium reports also showed that the patient had been having some hyponatremia, which was not that severe, but always he had. So when he was planned for discharge, he was stable now with fludrocortisone, his sodium was fine, so there was a plan for discharge, and because he was having a chronic low sodium, tolvaptan was added along with fludrocortisone. Luckily, the neurologist also sent an 8 AM cortisol because there was a postural drop of blood pressure, and the 8 AM cortisol was very low, it was 2 microgram per deciliter. So when we investigated further, he had very high ACTH levels. So that is basically Addison's disease. Now retrospectively when we have the diagnosis, there was all the history that was required to diagnose it. He had very severe weight loss, he had hyperpigmentation of the skin, mucous membranes, knuckles. He had required 40 units of insulin earlier, and now he was just able to maintain good sugar levels just with 6 units. So his sugar requirements his insulin requirements also had come down. So we had Addison's disease as the primary diagnosis. We do like to rule out other autoimmune diseases when we have Addison's, especially thyroid. So we also sent thyroid, and TSH was very elevated, so he also had primary hypothyroidism. So what I want to say here is that the hyponatremia was basically because of low cortisol and low thyroid, which was basically missed since last 1 or 2 years, and that is why he landed up with a severe hyponatremia. So patient eventually was started on hydrocortisone, fludrocortisone, which we give both these for primary adrenal insufficiency as well as levothyroxine. And now the patient is doing so well. He was a very active individual, very debilitated that he couldn't go to washroom also, and now they are so happy. They come to OPD for follow-ups, and he's again independent. So what I want to say here is that hyponatremia is a very common presentation in critical care. So especially if someone comes with euvolemic hyponatremia, we straight away think of SIADH, which I would like to point out is a diagnosis of exclusion. So any euvolemic hyponatremia, cortisol and thyroid should be checked because they are also the reasons for euvolemic hyponatremia. So only if these are normal and we are not able to identify anything else, then we make this diagnosis. Even if the patient has some other thing, even if the patient has a TB or a CNS disease, this is not the thing that we think of first. Our patient was also started on tolvaptan, which is contraindicated in hypovolemic hyponatremia. So that is also to be kept in mind. Euvolemic, hypervolemic, it's okay if we give it even if we don't know the reason, but hypovolemic we should always be very, very careful before we start the patient on tolvaptan. Any patient with postural drop of BP, a cortisol should be sent and evaluated. Again, a lot of times this is the presentation of Addison's, and a lot of times just with this history, Addison's is diagnosed. And any patient in the ICU with hypothermia, hypotension, hyponatremia and bradycardia, hypothyroidism should also be looked for. So that is the take home with this case.
What was the potassium of this patient? Potassium level?
Yeah, so I don't remember right now, but it would have been on the higher side since he had primary adrenal insufficiency, so 5.5. So case 3 is a 31-year-old female who came to the OPD with headaches, and she was found to have very high blood pressures of 210 by 100 millimeters of mercury. She was admitted to the ICU for this level of blood pressure. She was managed with NTG infusion, and the BP surprisingly came down just with this in a day. Other evaluations were done to see any endocrine effect of hypertension. 2D echo and ECG were normal. The fundus did not show any evidence of hypertensive retinopathy. Her creatinine and USG were also normal. So all the investigations for secondary causes of hypertension, since she was a young girl with so severe hypertension, all the secondary causes were sent. So secondary causes for Pheo, primary hyperaldosteronism, calcium, TSH, renal artery Doppler, everything was done. She was started on metoprolol, she was doing fine, so she was discharged and asked to follow up with investigations. So after a week, when she actually came to the hospital to show the investigations, because it takes time for all these reports to come, incidentally she also developed on the same day very severe breathlessness and cough with blood-tinged sputum. Again her BP had shot up. She was taking metoprolol quite sincerely. Her heart rate was high. She now was desaturating on room air, and there were bilateral crypts. So this time the chest X-ray showed pulmonary edema. 2D echo this time, which was normal a week back, showed that LVEF was just 30%, and ECG showed non-specific STT changes. So she was immediately shifted to ICU, and then again she was started on NTG, NIV and Lasix. Also MI was ruled out, her angiography was normal, but aspirin and clopidogrel were also given for benefit of doubt. The fever, there was no fever, WBCs were normal. Again she improved very drastically in just a day. Any guesses, such a presentation? Very high shooting BP normalizes immediately after a very minimal treatment in a young person. Exactly. So her plasma-free metanephrines were normal, but plasma-free normetanephrines, which we had already sent in the last admission, were very elevated. They were very elevated. The normal range was 200 below, and it was 1458 for her. So when we ask, of course, she says that she had been experiencing some headache, sweating and palpitations since 1 year, and the CT adrenal showed that there was a left adrenal mass. So she was on beta blocker when she was discharged, so that was stopped. And in any Pheo patient, that is something we don't want to start with. It can precipitate a crisis. So pre-op preparation with alpha blockage followed by beta blockage was done, and after that there was a right adrenalectomy that was done, and the patient is off any antihypertensive. The EF went back to normal. So she had a transient heart failure because of Pheo, which actually improved later on once the adrenalectomy was done. So take home message is that all young hypertensives should be evaluated for secondary causes of hypertension. That goes without saying. In a patient with unexplained acute heart failure, or even someone with non-cardiogenic pulmonary edema, if we are not able to find out some routine causes, do keep in mind that Pheo could be one of those factors that can cause both these things, although quite rare, but should be kept in mind if we can't think of anything else. Again, if we just send metanephrine and don't send anything else, a lot of times when we see if someone has been evaluated, what we see is metanephrine and VMA in a spot urine sample. So that is not how we diagnose. A lot of times we have seen only metanephrines being elevated in the patients. This is especially true for paragangliomas, when metanephrine will be completely normal. So if we don't check, we'll be missing out. So both these things should be checked. It is very important, and we do a plasma sample. So all the recommendations now suggest either a plasma sample or a 24-hour urine sample. So not a spot urine, a 24-hour, because usually a tedious task to do, so plasma is a good enough thing. It at least rules out, the sensitivity is very high, it's 98 to 100%. So both these things should be sent. And patients in whom we do think, a young hypertensive with a very rapid peak of BP followed by a fall of BP, ideally a beta blocker should be kept on hold for some time till we confirm whether the patient is having Pheo or not, because it can precipitate a crisis. Probably it did so in our patient as well. So we typically manage them with an alpha blocker first. Because in the blood vessels, basically alpha causes vasoconstriction. So we block that so that the patient has vasodilation. And once we have a good alpha blockade, then only we start a beta blocker. We also ask for good volume. So we ask them to take salt quite liberally as compared to any other patient, because they are quite volume depleted because of the vasoconstriction. The volume is very low inside. So alpha blocker followed by a good amount of salt and water consumption, followed by a beta blocker. That is how we prepare them for a surgery and then take them up for a surgery. A lot of times, a lot of case reports have also been reported where a Pheo was missed, and directly when they were taken for surgery for some other reason, there was a crisis which became a nightmare later on. So any young hypertensive, even if they are not given, another thing that I want to tell here is that we always try to look for that typical triad of having hypertension, palpitation, sweating. Most of the Pheos are not going to have that typical triad. They can just have a resistant hypertension, they can just have young onset hypertension. That is the most common way in which a Pheo presents. So if someone is not having clinically all those things, also we should look for Pheo with just two simple, very simple tests. So case 4 is a 52-year-old lady who was a known case of bronchial asthma. She was admitted with acute exacerbation in ICU, and she was managed with routine care. She improved, she was shifted to ward, and a day later when she was in ward, her sodium level was 159, and that is when we were called in. And just 2 days back when they had checked the sodium level in ICU, it was 147. So hypernatremia is something that we usually don't talk about, so I thought why not. So causes of hypernatremia mostly can be divided into two things: if there is unreplaced water loss, or if we give a sodium overload. Sodium overload, if we overcorrect with a hypertonic saline, or unreplaced water loss can happen if someone is having a lot of fever, so sweat loss, GI loss, renal losses. So renal losses can be either diabetes insipidus or osmotic losses, which can be because of glucose in DKA, or urea when the patient is in high protein RT feeds, or when there is a recovery of AKI, there is urea loss in the urine, so that can also drag free water along with it, or if mannitol is given to someone, or if there is primary adipsia. So again, these things are fairly common: GI losses, diarrhea, sweat losses in all fever patients. But not everyone goes into hypernatremia, not everyone develops hypernatremia. So why is that? Is because our body has beautiful compensatory mechanisms. If we start losing free water, if the tonicity of the plasma goes up, there is signal. So ADH basically goes up. It is an antidiuretic hormone, so it causes free water absorption from the kidney. And the most important thing is thirst. So there is a stimulus to our thirst receptor so that we start drinking water. So whenever we do lose water, we automatically become thirsty so that we replace that water loss. So these are the main reasons for hypernatremia. How do you evaluate them? So we basically check for urine osmolality first. If it is less than 300, it is straight away a diabetes insipidus. So urine osmolality dilute when the patient is already having high sodium, when serum osmolality is more. If the kidney is not, ideally the kidney should be able to concentrate, to pass a concentrated urine, but if the kidney is not concentrating, we know that it is diabetes insipidus. Whether it is central or nephrogenic, we give exogenous ADH, we give vasopressin, and the urine concentration should increase by 50% when we give it. And if it is increasing, then it is central diabetes insipidus, that is, the body is not able to produce vasopressin. So when we give it, it is able to concentrate. If the urine is still not able to concentrate despite giving vasopressin, then it could be nephrogenic diabetes insipidus. If the osmolality is between 300 to 600, we check for total solute excretion, which is basically urine osmolality multiplied by 24-hour urine volume. If it is below 1000 again, so this is a condition where there could be a partial diabetes insipidus, or it could be a solute load that could be there. So if after doing this the osmolality is below 1000 milliosmoles per day, then we again straight away diagnose diabetes insipidus. Partial forms are also there when there is no absolute deficiency, but there is little deficiency, it's less in the system. If the total solute excretion is more than 1000, then there could be a contribution from solute excretion, so glucose, mannitol or any other osmotic load should be checked for. If it is more than 600, that means our kidneys are able to concentrate the urine, so insensible water loss could be the reason for that. So coming back to our case, history taking, as was pointed out in the previous case presentations, is a very, very important thing. So when we went to ask for the reason of hypernatremia, our patient said that she had been having more urination since the last 15 years, and she had to get up in the night at least 6 to 8 times to pass urine, and she was also thirsty all the time. And when we looked at her old electrolyte reports, she always had a sodium which was on the higher side, between 145 to 147. Her HbA1c was normal, so she did not have osmotic gradient for that. And since she was admitted, since she was passing so many times urine, the sister in the ICU and the son in the ward told her not to drink so much water, because they were always attributing that increased urination to the more water that she was taking. So they had told, why are you drinking so much water, don't drink. So she was told to restrict water. So that thirst mechanism that I was talking about was stopped. And that is when all the compensation that was happening in her body since the last 15 years had failed, and her serum osmolality was more and her sodium went up. So urine osmolality for our patient was low, it was 134, so this was suggestive of diabetes insipidus. We gave her 5 units vasopressin and the osmolality increased almost more than double. So again, this is suggestive of central diabetes insipidus. We did an MRI pituitary because a lot of times we find something in the pituitary, either the bright spot is not there, posterior pituitary bright spot, or the stalk is enlarged, but her pituitary was normal, so it was idiopathic central DI. Management wise, while the time till we were awaiting the reports, we started her 5% dextrose, but once we knew that she had central diabetes insipidus, we just gave her a Mindrin tablet, desmopressin 0.1 mg before she slept, and we stopped because we didn't really want to overcorrect this. So next day morning, the 159 sodium report was in the evening previous day, and next day 6 a.m. sodium was 145. So that's the magic of desmopressin on DI. And again on follow-up visits, she's extremely happy because she had been complaining of this since 15 years. She was getting up 6-7 times in the night to pass urine, and everyone had ignored this, blaming that she was drinking more water, and she was extremely happy that she sleeps comfortably now. So small things make huge difference to someone's life sometimes. On follow-up, we are giving her Mindrin 0.1 mg daily. Her serum sodium is normal now. Whenever we give desmopressin, we are always concerned about hyponatremia, because we are again playing with the body's homeostatic mechanism. So we are concerned whether the patient can land up with hyponatremia. So we usually tell them to stop on Sundays. They do have excess urine, but that just balances out if any extra fluid, free water retention was there. So take home message is same, that all polyurias should be evaluated, and a lot of times a good history and examination tells us the diagnosis. When she told that she passes urine so many times, we knew that we are dealing with DI. So lab just confirms what we are diagnosing. Case 5, again a male with very high blood pressure who was admitted to ICU with 190 by 120 millimeters of mercury. So he was a hypertensive since 10 years, and he had been using cilnidipine and metoprolol. So when he was admitted, he was managed again with NTG infusion. His cilnidipine dose was increased, metoprolol was continued, prazosin was also started. So there was some doubt about compliance to medicine. So that is what everyone was thinking. Probably he skipped some medicines, and that is why the BP shot up so much. So when he was put on these 3 medicines, his blood pressure was around 150 by 90. He was stable. His potassium was 2.9. So he was discharged. We did want to evaluate for secondary causes, but since the potassium was low, we wanted to correct it. So we corrected the potassium for 4-5 days. When it was normal, we sent for the labs. I'll show that subsequently. So he also says that he had 2 such episodes in the past, and he's very concerned. Like, when I'm taking medicines, why am I still landing up with such high blood pressures once in a while? So we again sent not just for aldo and renin, we sent for pheo, we sent for all the causes for secondary hypertension. And of course, this potassium here, which was 2.9, was a very strong indicator that our patient could be having hyperaldosteronism. So the plasma aldosterone was very high, it was 33 nanogram per dl. His plasma renin activity was suppressed, ratio was 230. This is very suggestive, glaringly about primary hyperaldosteronism. So we did a CT scan and there was a bilateral adrenal hyperplasia. So for bilateral adrenal hyperplasia, also nowadays we suggest adrenal venous sampling because there can be a lot of false positives or false negatives just if we go with CT. So the patient did not consent for the same, so because he was not desirous of surgery. So we started him on mineralocorticoid receptor antagonist, we started him on eplerenone, started with 25 mg twice a day, up titrated to 50 mg. Potassium was 4.5. And this is his BP chart. He never had something like this in the last 10 years. His BP was always irregular, and after a long time consecutively his BP readings were always good. So here I want to say it is primary aldosteronism is a very ignored topic. The prevalence in earlier case reports was estimated to be 1%. But the newer case reports are showing the prevalence to be 10 to 20%, which is huge. So they say 25% in resistant hypertension, 20% in stage 2 hypertension, and 15% in stage 1 hypertension. So this is 1 to 2 patients out of 10 hypertensives that could be having primary hyperaldosteronism. So we don't screen them enough, that is why we don't pick them enough. Majority of these will have normocalcemia. So hypocalcemia is present only in 6 to 37% of the cases. Majority will be having normal potassium. So potassium is not a criteria for not screening them. So in general, screening must be done. Again, the newer guidelines are saying that you can just, so every hypertensive is what they are saying, deserves to be screened for primary hyperaldosteronism at least once in their lifetime, because the prevalence is so high and the morbidity and mortality is so high because they just don't have high blood pressures. They also have adverse cardiovascular events because of LV hypertrophy, MIs, strokes. They have CKD, they are at very high risk of having CKD. So that is why the benefits of treating such patients is huge and the prevalence is also huge. So we don't screen them enough. So we should be screening more of our hypertensive patients, especially if someone has hypokalemia. And mind you, it is not just spontaneous. Even if someone is on diuretic and we are blaming that diuretic for that low potassium, we still need to screen him. Or if the blood pressure is more than 150 by 100, if there is drug resistant hypertension, so 3 drugs, still the hypertension is not controlled. If the patient already has an adrenal incidentaloma, CT done for some other reason, found to have an adrenal mass with hypertension, screen. Sleep apnea, hypertension with sleep apnea is one indication. Family history of early onset hypertension or CV, any stroke less than 40 years in family, again that patient should be screened. And of course, if there is a history of primary hyperaldosteronism in the family, we need to be treating. Again, a lot of drugs interfere, almost all antihypertensives interfere with the aldosterone and renin that we check. But the newer guidelines say that you, other than mineralocorticoid receptor antagonist, rather than spironolactone or eplerenone, just go ahead and screen these patients and we can interpret the reports based on the antihypertensive. For example, ACE inhibitors and ARBs usually increase the renin. But if the patient is on ACE inhibitors and still his renin is low, then we can straight away make a diagnosis of primary hyperaldosteronism. So we can continue most of the drugs and just change it, and only if we think that the results are still ambiguous, that is when we change the drugs completely and then check for these. Thank you.